Hello, hello. Welcome, everyone. Everyone is trickling in. We'll get started very shortly. Let's see. Yes, I see the count popping up. There we go. Couldn't see it for a second. Welcome, everyone. I'm Jamie, Epicure's Head of Network Development. It is my privilege to welcome you all to this evening's clinical webinar. Each month, we bring together this fabulous clinical community of registered dietitians and gastroenterologists and pelvic floor therapists, which we'll be talking more about this evening, to give you awesome, heavy-hitting, relevant, timely content. This is all CPE certified. We do this every month along with other fun events, and we're really grateful for your time and to be here this evening. Before I get started, I have just a little housekeeping and introduction to do. So first, the housekeeping. You'll all be on mute for the duration of the webinar, but Dr. Phillips would be happy to answer your questions in the last 10 minutes or so of the presentation. So please, at any time, use the Q&A function at the bottom of your Zoom panel to submit any questions that you have for Dr. Phillips. She'll answer those at the end of tonight's hour. The session will be recorded. We do not share slides, but you will be able to access the recording later. You'll receive a link to that recording via email, and it will also have your CPE certificate attached. If you have called in tonight instead of signed in with your laptop, we will not have a way to associate your phone number with who you are, so please just reply to the email and let us know that you need the CPE certificate and the recording. We'll be happy to provide that. All right, so with that housekeeping out of the way, it's my pleasure to give you a brief introduction of Epicure. For those of you who don't know, we love working with clinical partners just like yourselves. We call this community our partners in health. All of the people across the country like you who are dedicated to improving health outcomes, leveraging the healing power of food, and that's where Epicure comes in. We love to create beautiful menus that create culinary experiences and bring joy back to eating for people on restricted diets. Our first menu is focused in digestive health, so it's all low in those pesky carbohydrates for those people who have IBS, Crohn's, colitis, SIBO, and it's all gluten-free as well, so good for those who have celiac and non-celiac gluten sensitivity. We like to call it Mediterranean with a twist because it is very veggie forward. For those of you who aren't familiar with low FODMAP, it can be complicated. We won't go into all the details this evening, but it works. There's now over a decade of research showing that up to 86% of people with IBS can have symptom reduction and up to 78% of people with IBD. So we're honored to be part of the care plan for these individuals who find relief from their symptoms through low FODMAP food. For those patients that you have who may benefit from eating low FODMAP, it can be helpful to leverage this elimination phase friendly food as a diagnostic tool. Maybe you don't want to go into the ins and outs of the complications of low FODMAP, or they have disordered eating or eating disorder and maybe aren't a good candidate to go into that depth. But leveraging Epicure for 3 to 5 days can show whether or not low FODMAP actually improves their symptoms. All of our meals are fully prepared, ready to heat and eat. So it takes the stress and guesswork out of low FODMAP and gives patients the peace of mind knowing that food that makes them feel good is going to show up at their door. And finally, as I mentioned, it really is a Mediterranean style diet with a ton of plant diversity, fiber, and other nutrients that are commonly lacking in a low FODMAP diet. We take great efforts to make sure we've got an expansive array of options within those elimination safe thresholds of low FODMAP food. And finally, we love bringing resources like tonight's webinar to all of you. We also have a resource portal you all get a link to after tonight, brochures and patient educational materials, and of course, a blog full of other wonderful content. But why I gotta get out of bed every day is because people tell us all the time how good our food makes them feel and how grateful they are to all of you, the doctors and dietitians who refer them to Epicure as a helpful tool. And so without further ado, it's my pleasure to introduce you to tonight's lovely presenter, Dr. Caryn Phillips. She is PT and DPT. She is the founder of Mom Life Health and Wellness. You can follow her on Instagram. She's got a great account at Mom Life Health. And she is a pelvic floor and perinatal physical therapy practice, or has a practice. She's been specializing in pelvic floor and perinatal physical therapy for over 10 years after completing her master's of physical therapy from the University of Connecticut and doctorate of physical therapy from the MGH Institute of Health Professions. She has completed numerous trainings for treatment techniques and myofascial release, prenatal and postpartum exercise, yoga for pain, and more. In addition to patient care, Caryn assisted in developing a brand new pelvic health program in a major Boston hospital. And she is the mother of two lovely boys, Brayden and Oliver, and lives with them and her husband in Franklin, Massachusetts. So without further ado, Dr. Phillips, I will let you take it from here.
Thank you, Jamie. Let me just...
My pleasure. We're so grateful to have you.
Yes, I am very grateful to be here and share this information with everyone.
We had incredible registration, so it's clear that this is a very in-demand topic. You serve a very important need within this patient and clinical community.
Well, hopefully, thank you. Hopefully everyone will find this helpful. All right, let me see. Let me just start presenting. All right. So tonight's presentation is going to be on the pelvic floor and gut health and the gut health connection. And you'll find it's not just going to be about the pelvic floor. It's going to be about a lot of other muscles, kind of like the whole musculoskeletal system we look at, because everything is connected. So while the main focus is the pelvic floor, you'll see it's not just about the pelvic floor. And then Jamie did kind of touch on all of these bullet points. So I'm not going to read through this slide, but just a little bit about me and my two boys, which this picture was a couple years ago, so they're a little bit bigger than that now. And tonight's objectives for this webinar are going to include that you will learn the 4 main ways the musculoskeletal system contributes to constipation. You'll learn the basic anatomy and main functions of the pelvic floor muscles. You'll learn self-management techniques for patients with constipation. You'll learn when to refer a patient with constipation to physical therapy. And you will learn what the physical therapy evaluation and treatment may entail. All right, let me just... Okay, so first we're just going to start with what physical therapy actually is, the definition of it. Physical therapy is a practice of healing that restores function and reduces pain through the use of techniques to improve bony alignment, reduce trigger points, and improve muscle coordination and strength. And then the sub-branch of pelvic floor physical therapy is just a branch that is built on these same principles, but we just, go into greater depth in this area that is the pelvic floor and surrounds the pelvic floor. It's a specialty. You don't learn about pelvic floor physical therapy in PT school. You have to go to continuing education and be certified in it afterwards. So the same principles apply as regular physical therapy, but you're just now zoning in on this particular area. And a colleague of mine said, pelvic floor PTs are the musculoskeletal, neuromuscular, and biomechanical experts of the pelvis and pelvic girdle. So we're just interested in how these muscles affect the pelvic area, how movement affects the pelvic area, and you'll kind of see that as we go forward in the presentation. Okay, so these are going to be kind of like the 4 main ways that the musculoskeletal system contributes to constipation. I'm going to be referring to them as the presentation goes on. So I'm kind of presenting them now, and we're going to go into more depth about them. So the first way is through dysenergic defecation, which is kind of the most well-known diagnosis, which would send someone with constipation to physical therapy. It's what the GI doctors know the most about. So that's kind of, I would say, in the GI world, the most well-known one of these four. But then there are some other ways that the musculoskeletal system contributes. The pelvic floor muscles can have a high resting tone. That's number two. The muscles that are around the pelvic floor that have fascial connections can be tight and then therefore affecting the pelvic floor. And then the last is that tight muscles in the abdominal and pelvic girdle can contribute to slow transit constipation. Most of the time, when you're thinking about pelvic floor PT and constipation, you're thinking about outlet dysfunction and the act of the stool coming out of the rectum. But it can also, pelvic floor PT can also help with more slow transit constipation. There can be these various restrictions that can affect the way that the abdominal contents move through the abdominal cavity, and we'll get into that more as we go on. So first, we're just going to have a little anatomy lesson about the pelvic floor, very basic and brief. This is a view of the pelvis if you were looking in from the top. This pink area is the pelvic floor. It lines the bottom of the pelvis, and it is made of muscles, and then that like light blue color is ligaments. But the muscles are what we can do something about. The ligaments, they're not contractile, they're not adaptable to change really. So we're more focused on the muscles. And like any other muscle in the body, the pelvic floor contracts and it relaxes. Another thing to note is that going from bottom to top, in a female pelvis, the urethra, the vagina, and the rectum all run through the pelvic floor muscles. So you can imagine that if there's something going on with the pelvic floor, all three of these areas can be affected by that. Here's another illustration showing a side view, kind of like cut down the midline, showing that the pelvic floor muscles are hammock shaped. They connect from the tailbone in the back to the pubic bone in the front. There's actually 3 layers of muscles, and this illustration kind of shows the first and third. So in the first layer, the sphincter muscles are involved, and there's a sphincter around the urethra and there's a sphincter around the rectum. And then the one that we focus mostly on and that most people are familiar with when you hear to do Kegels is the third layer, which is the levator ani. That's that larger hammock shaped muscle that's going from the pubic bone to the tailbone. But this is just significant because the sphincter, especially when we're talking about constipation, it is a more circular shaped muscle and it is being controlled by the deeper muscles. So if you cannot relax the deeper muscles, the sphincter is not going to be able to open as well. And we'll get into that more, but that's kind of why knowing that there's these layers is important. And I believe that that's it for that. And then we're just going to quickly review these main functions of the pelvic floor. We're going to be focusing mostly on one, but I just wanted you to know them all. So the pelvic floor has these 4 main functions. They're called the 4 S's. And the first is they are supporting the abdominal and pelvic organs. So if there's an issue going on, one may have prolapse of their bladder or their uterus or their rectum if the muscles are weak and unable to support these organs. They can contribute to sexual function. There definitely can be a correlation between pelvic floor dysfunction and painful intercourse. If there's too much tension in the pelvic floor muscles, that can lead to pain. And then on the other hand, if there's not enough strength or tone in the pelvic floor, it can be hard for someone to reach climax. Sphincter control is the third function, and that's sphincter control of the bladder and bowel, and that would include incontinence if the muscles were too weak, and then issues like retaining urine or constipation if the muscles are too tense. And then the last function is it works to stabilize the pelvic girdle along with the other deep core muscles. So that's where its function can contribute to people having low back pain or hip pain, if there's issues going on with the pelvic floor's ability to stabilize the pelvis. But like I said, we are going to be mostly talking about sphincter control. And here's a little bit more about that. This image is showing the bladder and urine, but it's similar to the bowels. So the pelvic floor, the muscles of the pelvic floor wrap around the openings of your bladder and rectum. That's that sphincter muscle I was talking about. And then the muscles are supposed to contract around these openings. That would be to prevent leakage. So basically, you want these sphincter muscles closed when you're going about your day, coughing, sneezing, laughing, lifting. You wouldn't want these sphincters open, or that could result in urinary or fecal incontinence. And you want them to be closed when the bladder or the rectum is full, or else you wouldn't have control and could also have incontinence. But then on the other hand, the pelvic floor muscles have to lengthen to allow us to urinate and have bowel movements easily. So if you can imagine, when you contract and you're closing these sphincters and holding everything in, you need the opposite to happen in order to let that urine out or let the stool out. So the lengthening is the, takeaway of this, is that that's especially with constipation, where that's kind of what we're focusing on. We need the pelvic floor muscles to do. And this is just a slide kind of comparing the pelvic floor to like the bicep muscle, because all muscles have the same, they're all the same. They all contract, they all relax, they all have a range of motion. They can be weak or they can be tense. So if the pelvic floor is not working correctly, it can result in a dysfunction. And this video, if it works, is just kind of explaining how the pelvic floor can go through a full range of motion or a limited range of motion. Oh, maybe it won't work. There we go. So this is full range of motion. It's contracting, it's relaxing all the way. Contracting. Now she's showing if the muscles can't relax all the way, that's kind of the comparison with the pelvic floor. She's not letting the muscle fully let go. And that can happen if someone is not relaxing their pelvic floor fully. Okay, so we went over the anatomy and the main functions. Now we're going back to those four components of how the musculoskeletal system contributes to constipation. So the first one was dysnergic defecation. Dysnergic defecation is defined as the inappropriate response to bearing down to have a bowel movement. So basically, like I just mentioned, when you sit to have a bowel movement, your pelvic floor and your external anal sphincter are supposed to relax. In this diagnosis, dysnergic defecation, the opposite occurs. So the person sits down, tries to push, and then their muscles contract instead of relax. So you can imagine if that sphincter is closing, the stool is not going to want to come out. This can be medically diagnosed by a GI specialist via a test called anorectal manometry. And that is why, like I mentioned before, because there's this diagnostic test to confirm this diagnosis, that is what the GI docs are most familiar with. So they will be sent to physical therapy. They'll be told to do biofeedback, which is the most studied line of treatment. And biofeedback is basically a measure to, biofeedback just means that there's some external factor teaching the person how to do what they're trying to do. So in most cases, there's a rectal sensor that goes inside the patient, and they are asked to contract their their sphincter muscles and pelvic floor. They're asked to relax, and there's either a screen or some auditory stimuli that when they do the right motion, they're getting that feedback. And like I said, that's what's been studied most because there's objective data with this type of biofeedback machine. It is shown to work. It's shown to teach the patient how to relax their pelvic floor correctly. But there are other ways to help patients with constipation besides biofeedback. A lot of the time I've found that I've accompanied some patients to this test, and it's a pretty intimidating environment. You have no bottoms on, you have multiple people in the room, and for the test, they put a sensor in your rectum as well, or a catheter, and are asking the patient, contract, contract, bear down, and they're just watching the graph to see what the muscles are doing. So you could imagine a patient may get confused or not give the right, do the right thing on the first try, but then with that data, they give the diagnosis. So I often find that even with this diagnosis, once I do my assessment, even with some of my cueing, they're able to correct this this inappropriate muscle response, and things can get better rather quickly. Some risk factors to dysnergic defecation include those with longstanding constipation, a history of excessive straining, longstanding use of laxatives, history of sexual abuse, or any rectal trauma. And like I said, with just back to dysnergic defecation, the first line of treatment is the biofeedback, but we may also find what I'm about to talk about now, which is high pelvic floor resting tone. So this is that second, number 2 in our list of 4 things that how the musculoskeletal system contributes to constipation. Pelvic floor resting tone is where your muscles are supposed to be at rest. So when there's a high resting tone, it means that the pelvic floor is in a more tense position than it should be just at rest. So the person's basically walking around, if their muscles are supposed to be in a relaxed position, they're walking around with them in kind of like it can range, but a 20% tense, 50% tense position, and that's just their normal. So then when these people go to sit on the toilet to have a bowel movement, they have built up these tissue restrictions in their pelvic floor, and they are having trouble letting go when they go sit on the toilet. They're not necessarily having dysnergic defecation where they're doing the opposite. They may be trying to relax, but their muscles won't allow them to relax, or they don't know how to relax. So people with high pelvic floor resting tone may experience that and have trouble getting the stool out. And this is usually assessed vaginally or rectally by a urogynecologist or a pelvic floor PT. The main pelvic floor, and I'm going to get into this also with the pelvic floor exam or evaluation, but the main way to assess the pelvic floor muscles and their resting tone and strength and range of motion is vaginally. You can feel, like, palpate the most of the muscle that way. When it's indicated, we can do a rectal exam to see if the sphincter muscles are working, but you don't get a ton of more information rectally about the pelvic floor than you would vaginally, except if we're specifically concerned about that sphincter muscle. Some risk factors of high pelvic floor resting tone include pregnancy and childbirth, especially if the babies were larger or there was tearing, abdominal or pelvic surgery, trauma or injury of the hip or low back or pelvis. Just overall stress can cause someone to have higher resting tone. That's kind of similar to if you hold stress in your shoulders or in your jaw, you can hold stress in your pelvic floor. Posture can contribute to a higher pelvic floor resting tone. And if you are weak in other areas, like other deep core muscles or hip stabilizers, the pelvic floor maybe tends to compensate for that. Some other symptoms, so constipation would be one, but some other symptoms of high pelvic floor resting tone, and this could be kind of red flags if you think someone might have pelvic floor dysfunction, would be urinary frequency and urgency, or nighttime frequency, like getting up a lot to go to the bathroom, inability to empty the bladder completely, difficulty starting the flow of urination, frequent urinary tract infections, painful intercourse, or pelvic pain. And then treatment for this would include, it could include biofeedback. It may include breathing strategies. There's ways to breathe to help let go of the pelvic floor muscles and to assist with that lengthening of the pelvic floor. Toileting position can help. Specific exercises, stress management, and then there's manual internal work that can be done to release areas of restriction in the pelvic floor. Okay, so our third contributing factor would be the fascial connections of the pelvic floor. So fascia is basically connective tissue in the body that's role is to attach, stabilize, separate muscles, and enclose different organs. So it's basically the tissue between everything else. Like if you have muscle and organ and another muscle, the fascia is all of that interweb in between that's kind of connecting things in that in between space. The pelvic floor shares fascial connections with a lot of different muscles, including the hip flexors, the low back muscles, the inner thigh muscles, the adductors, the glutes, even your calf and your rectus abdominis, like the abdominal muscles. So this is important because if there's issues with these muscles, if there's tightness occurring there, then it can affect the pelvic floor's resting tone or its ability to relax. So there are manual therapy techniques and then stretches and self-massage techniques that can target these areas as well. And we'll want to look at that in a patient with constipation. And then the last factor here is a little different. So the first three dealt with outlet dysfunction. That is, when a person is having a difficult time getting the stool out. They may feel like they need to they may feel the urge to have a bowel movement, but when they go to sit on the toilet, it's not coming out, or it's coming out in small pebbles, or they feel like it's incomplete. So that all those first three things we're dealing with outlet dysfunction. Now we're just talking about slow transit constipation, where the abdominal contents are moving slowly through the digestive tract. So the person is having days and days without the urge to have a bowel movement. So physical therapy can help with this too, in the sense that there are tissues like muscles and connective tissues that can be restricted throughout the abdomen that can affect how quickly the contents move through the digestive tract. This can include muscle tightness, scar tissue, or posture abnormalities. And it can actually affect the positioning of the large intestines. It can make it more difficult. I'll find up in someone's corner where their large intestine changes positions near the rib cage. That's often a place where things can get stuck, and it can be due to diaphragm tightness or postural changes. So there are manual techniques that can be done to improve these restrictions or break up scar tissue. And we definitely talk about posture and breathing and all of those things too. But don't rule out PT for the slow transit constipation as well, especially if they're sitting in your office or you're on a Zoom call and they're sitting in a slumped position. There can be a lot, I know you can't see my stomach, but there can be a lot of restrictions in the abdomen from sitting like this all day. Okay, so now we're going to go over some self-management techniques for just general constipation. These are appropriate for anyone to discuss, with their patients. There's things that can be done. You don't need the guidance necessarily of a pelvic floor PT, and they can be suggested. So the first is bowel massage. It is shown to increase bowel movements and decrease GI symptoms, including constipation and abdominal pain. And it can be helpful for bloating, gas, and fecal incontinence. So basically, you're just running along the large intestine. I tell people, ideally, you do this in the morning after you've had tea or coffee or a hot warm water, something warm. And then about 10 minutes later, I mean, not everyone has this time, but this is the ideal situation. You lay down and you do your bowel massage for 10 minutes. If they can't do that, I say, even if you sit at your desk and go along the large intestine, it can be more helpful than if you didn't do it at all. So try to be realistic, with their expectations, but you're basically going along the direction of the large intestine. So you're starting at the right hip bone and you're gently pressing down into your abdomen and moving up to the right rib cage, across to the left rib cage, and then down to the left hip. And you can repeat this multiple times. If you feel an area that there feels like there's gas pain there, you can kind of stay there and work it out a little bit. There's no really wrong way to do this unless you're like going in the completely wrong direction. So it's pretty foolproof. Another tip would be toilet positioning. So in order to have a successful bowel movement, you want your pelvic floor muscles to relax. It's been shown that the pelvic floor muscles can relax easier in a squatting position. So the knees being above the hips. This position also helps to straighten out the anorectal angle, which is a section of your bowels, and it gives the stool an easier exit. So there's multiple reasons why this squatting position is a good way to be sitting when having a bowel movement. And research shows that being in a squat position may reduce straining and decrease the time it takes to have a bowel movement. So for this reason, it's recommended to place a stool under your feet when having a bowel movement. I'm sure most of you have heard of the squatty potty. Those are on the left and right. They've come out with all different designs and finishes now. It used to be this white one, I believe, when they first came out. And in my other office space, we have one of the wooden ones, but people don't have to go out and buy a squatty potty. They can use a step stool, they can use a box, they can use a pile of books. It doesn't matter as long as they're resting their feet on something that's positioning their knees above their hips. Another self-management strategy would be stretching. And like I said before, there's a lot of muscles that are connected to the pelvic floor via fascia. There's actually 45 muscles connected to the pelvis. So if there is something going on in a surrounding muscle, it can also affect the pelvic floor. I've put a few stretches here that can be helpful, kind of targeting areas that tend to be tight in people with tense pelvic floors. This first stretch is like a figure 4 piriformis stretch. It's kind of self-explanatory. You do it on both sides. You want to make sure that you're not, tensing your neck as you're holding your leg. You should be kind of relaxed. And feeling a stretch in your glute for this one. This is a hip flexor stretch. That's the front of the hip. And again, another area that definitely when that's tight, it can affect the pelvic floor and the digestive tract. I find a lot of people who are backed up in their large intestine have tight hip flexors. So opening that area up is important. And then child's pose is a great one. This has a few benefits. It's helpful to stretch out some of the low back muscles, but it's also a great position to relax the pelvic floor. Anytime, basically the same way how we said the knees being above the hips, like when you're sitting on the toilet with a stool, that relaxes the pelvic floor. So in this position, if you think about it, the knees are above the hips as well, just in a face down position. So that is also going to help just automatically lengthen the pelvic floor. So I'll give people breathing exercises to do in child's pose because they can really expand their belly and relax their pelvic floor. And that brings us to breathing strategies. So there is a breathing technique related to diaphragmatic breathing that can help relax the pelvic floor. And you can see it in this video that I'm trying to say it at the right time here. So I think hang on, I'm looking at the way that this changes color. So when the top is the diaphragm, the side is obviously your abdomen, the bottom's the pelvic floor. So when you inhale, your diaphragm is flattening, your abdomen is expanding, so your belly comes out with a diaphragmatic breath and your pelvic floor relaxes. So basically, this is the how I'll instruct people to do this. Imagine your whole tummy as a balloon and that you're filling it with air. At the same time, focus on the area between your sitting bones and relaxing and widening to allow the pelvic floor muscles to lengthen out and go. So you're basically inhaling, bringing the breath into your belly so that your belly expands and your pelvic floor lengthens. It can take a few practices, but the inhale is where everything relaxes. And then the exhale, you're not tensing, you're just kind of recoiling back to the starting position. So here are a few kind of more red flags of when it may be appropriate to refer someone to pelvic floor PT, or when you may change, shift your mindset to think it might be pelvic floor involvement related to this person's constipation. If a person is complaining of an urge to have a bowel movement, but difficulty passing stool. So if it's outlet dysfunction, it's like 99% going to be the pelvic floor, because the stool is there, it's waiting to come out and they're unable to get it out. So it has to be these muscles that are tense and not allowing it to come out. Slow transit's a little different. There can be a lot of factors, but if they're complaining that they have the urge to go, but it's not coming out or it's incomplete, there's most likely a pelvic floor issue. If a patient has abdominal pain or bloating, if a patient's stool consistency is soft, yet they still complain of incomplete emptying. So that one I added in because I see this a lot where a GI doctor or a dietitian, they're working on fiber, they're working on getting the stool softer to help with constipation. And sometimes people's stool does get softer, but they're still not feeling like they're emptying all the way. So something's coming out because it's softer, but it's either, not to be gross, but they'll describe it as like stringy, or that it's just not complete. And that's because the muscles are still not relaxing all the way. The sphincter isn't opening all the way. So even though the consistency problem was solved, the mechanical problem of the muscles relaxing is still there. So that's a good one if anyone ever complains of that. And then if the patient has any bladder symptoms that go along with it, so urinary urgency or frequency or incontinence, if a patient has pelvic, back, or hip pain, or if a patient has pain with intercourse. This tool, which the link is here if you want to screenshot it, or feel free to message me for the link if you miss it. This is a screening tool with a 91% specificity rate that basically, if you give it to a client and they check off 3 or more circles, they likely do have pelvic floor dysfunction. So it's a great tool that's printable for free. One of my colleagues created it, and it's great to screen for pelvic floor dysfunction. And then I just wanted to mention kind of what goes on in a pelvic floor physical therapy consult, because I've had some conversations with dietitians where they think that there has to be internal work done, and that can make people shy away from it. The internal assessment or treatment may be most beneficial in some, but there's always the option to avoid it if somebody doesn't feel comfortable. So I wouldn't want that to be a reason that somebody never went to pelvic floor PT just because they were scared of the internal piece of it, because we can work around that part of it, and there's other things that can be worked on. And that's how I'll phrase it to people when they come in and they weren't aware that maybe there'd be an internal assessment. So we'll work on everything we can externally, and it may help. It may not help as much as if we did any internal assessment or work, but I'm definitely, and I would think most pelvic floor PTs are definitely willing to work with them to do what they can within those limitations if they're not comfortable with that. So that was a little soapbox. In a pelvic floor PT consultation, we're going to do a thorough history taking, including their medical history, what they do for physical activity, work, social activity, their diet, their fluid intake, and sexual history. There will be an internal vaginal pelvic floor exam if indicated, and there could be a rectal pelvic floor exam if indicated. There will always be an external musculoskeletal and neuromuscular exam to assess posture, breathing, strength, motion, flexibility. And then in that first visit, lots of education on what we found and what we'd recommend as the next steps. And then treatment, I went over this in a few of the slides, but overall treatment could include, but wouldn't be limited to, exercise based on what their limitations were, possibly biofeedback, manual body work, relaxation training, behavior modification training, and customized home exercise programs. And that is it. Here's my contact info. Like I said, if you missed anything or wanted that link or any of the other information I was speaking about, you can email me, you can message me on Facebook or Instagram, follow me. I'm almost at 2,000 followers. And thank you. And I think we're going to be doing the Q&A when Jamie, I think Jamie's going to hop back on.
There we go. I'm unmuted now. Sorry about that. All right, so we've got a bunch of questions. For those of you who do have questions and have not yet submitted, please do so with the Q&A function at the bottom of your panel. Let's start out with a question from Diane. Is bowel massage best done standing or lying down?
It is best done lying down because you can fully relax in that position. So I would say lying down either fully flat, or you can lay in bed, you know, with your head on a pillow, or even at an incline if you were kind of like laying in a recliner. But when you're standing, you kind of have to use your abdominal muscles. So they're not going to be, things aren't going to be as relaxed as if you can lay down. But that being said, it can still be somewhat effective if the only time you can find in the day to do it is sitting, or if you are sitting at work and some gas pain comes on or something, doing a little bit of abdominal massage, even sitting, could provide some relief. So it can be either, but ideally or best would be lying down.
Great, thank you.
Mm-hmm.
And from Nicole, have you seen patients with abdominopharyngeal dysnergia, APD? I'm sure I butchered that, so bear with me. And do you use similar physical therapy techniques for these patients compared to PFD patients?
Um, yes, I would say I have not seen it diagnosed often, but this is basically when I believe the muscles in the abdomen just aren't contracting, things aren't moving through the way that they are supposed to. And this could also be due to either a excited nervous system or muscle restrictions. So you're going to be doing similar treatment to kind of do this breathing to calm down the nervous system, get things moving. But I also would find in these people that they're going to have a lot of restrictions through their abdominal muscles, through their diaphragm, probably through their hip flexors. So similar to what you do with like what I talked about with the slow transit constipation patients, and everyone can benefit from some down training of the nervous system. A lot of this stuff can be perpetuated if the nervous system is kind of in one of those like hypersensitive cycles. So it would be similar to what I discussed for the pelvic floor patients. Yes.
Sure. And what's the gender makeup like of your practice? Do you see men with pelvic floor dysfunction, or is it primarily women?
I see only women. Basically, my practice is probably targeted more towards the moms based on the name of my business. But people come for all different reasons related to the pelvic floor. But I do not treat men. There are pelvic floor therapists that do. Men do have pelvic floors and can have pelvic floor dysfunction as well. It may present differently, but in my practice, I do not see men.
Got it. Lots of props in your presentation. So just sort of want to reiterate that everyone thinks this is amazing.
Okay.
Thanks, Nicole, for those props. Nicole also asked, would someone with Parkinson's be a good candidate if all other signs point to pelvic floor issues?
Yes, I would say so. Yes, because again, from their Parkinson's, there could be a number of muscle restrictions related to some of the neuromuscular component of that condition will make some of these things that I talked about today more prevalent. So they would benefit just as much as anyone else.
Sure. Sarah says she sees a lot of clients with both chronic pelvic pain and hemorrhoids. Can you explain if there's a link between the two?
Hemorrhoids, I do believe, can be more common in people with higher tension pelvic floors. If you kind of think about how I was talking about, if things are closed off and tense, the stool is going to have a harder time coming out. And I think that the straining is one that will cause hemorrhoids, but then they will continue to get aggravated because every time the stool passes through, it's not like there's not enough space for the stool to come through. So when people have higher tension pelvic floors, they're going to be straining more. They're more likely to get the hemorrhoids, and then they're more likely to get aggravation from their hemorrhoids. And then definitely pelvic pain can be related to tension in the pelvic floor. So yes, I would say that there's a link between the two.
Mm-hmm. We have a lot of questions about finding specialists in pelvic floor therapy. Is there a directory that you know of that you can point folks to? And beyond that, what sort of credentials should other clinicians look for when choosing a referral partner for pelvic floor therapy?
Yeah, there is a directory. I don't know it right off the top of my head. I can definitely get that to someone.
Perfect. Yeah, you can send that to me. And for everyone who asked, and we did have a lot of that question, we'll include it in the email that we send out with the recording and CPE certificate. Emily says maybe pelvic guru or
Yes, I was
rehab.
going to say pelvicguru.com, and then I don't know the link right to the directory, but if you go to the website, there's a directory. There's a button you can push to be brought to the directory. So that's at pelvicguru.com.
Great. And in terms of training and vetting a referral partner, do you have guidance for that?
That is kind of difficult to say. Most, I would say, just to look at their website and see what their services are. I mean, probably not all pelvic floor physical therapists deal with constipation or bowel issues as much as others, but I think that they would, say that when they had their list of services on their website. I would say if they treat it, they've likely had training in it. That being said, everyone can have a different approach, so it's hard to, until you meet them, kind of know what their approach of things is going to be. Usually in the Pelvic Guru directory, I would say there are wonderful clinicians in there. So if you're finding them through there, that's good. And then probably word of mouth, or it's hard to know unless somebody goes to see them. I would tell any patient that if they don't like the feeling they're getting from them, to find someone else and not to stick with them. Or if they feel like, they're getting worse. I get a lot of people who work with people for a while and it doesn't help them, but they just continue to do what they say because they're the specialist. But I would just, reiterate to your patients that, if they don't feel comfortable or they don't think that it's helping, that it might not be the right treatment. But yeah, it's hard to know everyone's style until you're actually working with them.
Sure. And besides just sharing the directory in the email, Epicure is always happy to be kind of a connective body for anyone who is not sure to talk to or where to go. We'll do our best to connect any and all of you with the appropriate resources or clinicians in our network to help get answers to these things when you hit a roadblock. This is more an insurance related question, but it's kind of a tangent to this. Do you know, is a referral, a specialist referral from like a GI provider typically needed in order to get a pelvic floor therapy consult?
It depends on the state.
Yeah.
And their direct access laws. Some states, like in Massachusetts, people can go to any physical therapy. Pelvic floor physical therapy is included under physical therapy. So anyone can go without any doctor's referral. Some insurance companies do require authorization. So it depends on the company and the state, I would say, for that situation. But it shouldn't have to be the GI specialist. I would think it could be any doctor, any of their providers that gives it. It could be a primary care. It wouldn't have to be the specialist.
Mm-hmm. Great. And we also had a request to include the link for the questionnaire in our email, and we can certainly do that if Dr. Phillips shares with us.
Mm-hmm.
Okay, so next question is from Linda. Could high PFM resting tone cause an occasional cramp of the rectum? Nearly always happens during the night, she says.
Yes, definitely, I would say.
Mm-hmm.
It's the pelvic floor tension, like the high resting tone and tension in the pelvic floor can present in so many different ways that it can be confusing. But any type of like spasmy feeling or sharp pain in the rectum, in the vagina, at the tailbone, like could be from higher tension in the pelvic floor. So I would say that's definitely possible.
Mm-hmm. Does intestinal massage work for the occasional gas and bloating symptoms without necessarily having other compounding pelvic floor issues?
Yes, it can.
Great. When on toileting practice, what part of the breathing to facilitate bowel movement is most challenging or hard to master, would you say?
I think that the hardest thing for people to master is the coordinating the diaphragm breathing with relaxing their pelvic floor. That piece of it, like how I was talking about visualizing the balloon and the belly expanding as the pelvic floor is relaxing, that can take some time to practice. It's interesting. Some people pick up on it right away, like in a visit when I explain how to relax your pelvic floor. Some people can do it instantaneously, and it doesn't solve all their problems, but it could solve like 70% of their problems, just gaining that awareness of how to relax their pelvic floor. And then there's some people who can't make that mind-body connection and can't, like, even though they're trying to do what I'm saying, they can't, whether it's that their body has never done it, or it hasn't done it in a long time, or they have too much tissue restrictions. So it definitely can range. Like, some people have that connection and can get it instantly. And then some people, it could take a number of one-on-one sessions to get them to have any noticeable relaxation of their pelvic floor. So there's a big range with that.
Sure. And I think that ties into a very common question. And I think the answer is going to be, it depends, it's a range, but how many visits do patients usually undergo for these conditions?
Say it one more time.
How many visits do you normally have with a particular patient, or what's the range? I'm sure it depends heavily, but is there a sort of expectation that people might set?
Um, eh, it does range. I mean, when I talk to people, I say this can be, I would expect at least 6 to 8 visits usually. It can be less. Like I said, some people can get what they're supposed to be doing and it solves all their problems and they only need a couple visits. 6 to 8 is probably the average, but then you have people with long-standing constipation, or if they've had history of abuse, and they're just having a really hard time getting things to move the way that they're supposed to. It can go on for months and months. So there's definitely a wide range.
Sure. And in terms of making a referral, if a clinician only can check 1 or 2 items on the screening protocol, do you feel it still could be appropriate to refer a patient for pelvic floor therapy?
Yes, I don't think there's any downside to anyone having, I think everyone in the world should have a pelvic floor evaluation. So I don't know if I'm the right person to ask, but yes, I would say if there's suspicions and they don't necessarily check off 3, that's just showing that it's very likely that they have something going on with their pelvic floor. But if there's reason to believe otherwise that there might be, then I would send them anyway, because the worst case is that their pelvic floor is fine and they don't need pelvic floor PT. But I feel like it's worth looking into if you're suspecting it.
Mhm. What nutritional sort of elements might affect or improve even pelvic floor GI issues? Well, I should say pelvic floor. That's a bigger question for GI issues. But does good hydration and dietary fiber, for example, potentially improve pelvic floor issues?
Good hydration definitely does. Um, the fiber, I wouldn't say directly affects the pelvic floor. It can affect constipation for other reasons. Definitely, if stool is harder or larger, it's going to be harder to pass through. So, in terms of getting the pelvic floor to work correctly, you're looking for like firm to soft stools. If it's too soft, that's a problem too. That's when I mentioned in one of the slides that prolonged use of laxatives, like if the stool is too soft and somebody doesn't, they don't even need to use their pelvic floor for it to come out because it's so soft. And sometimes the laxatives have that, pressure effect where the pressure is what's letting the stool come out. It's not that you're using your muscles to help the stool come out. So you do want to make sure that their stool's not too soft. So sometimes like a bulking agent can be helpful with that. Nutrition's not my specialty, but that I do like the idea of somebody having like a soft, but still like the edges still, you want there to be, what's the word I'm looking for? Like
Formed.
formed, yes. Formed is the word.
Yeah. And what about, so this answered a couple of questions that were in the Q&A panel, but we had a particular question around one very large, described as 10 inches BM per week. There wasn't a whole lot of more context than that, other than asking for your thoughts on perhaps what that means or therapy needed for that.
Probably. I mean, I guess one per week. I guess my thought would be that it's backing up, having trouble evacuating. And again, this is just my initial thought with this, that they're having trouble getting it to come out. So it kind of builds and builds and builds until, I don't know if there's some facilitator that helps them to have their bowel movement, whether they're taking a laxative or doing anything to stimulate that. But I would imagine they're having trouble evacuating if it's getting to that point that it's that large and that it's only once a week.
Yeah. Sounds like it's regular, soft and formed, but yeah, not much more context. Sounds like there would be more, conversation that would need to have to better
Probably.
understand that. They need a referral to you, Dr. Phillips, is the answer there, right? Maybe a couple more questions. I know we're just 1 minute over. Couple of, I think, relatively quick ones. Does the position of the uterus, like having a tipped uterus, for example, affect bowel issues?
It is not shown to. I don't think too much. I think that everything should be able to move enough that it shouldn't really affect bowel issues. That being said, it's possible, I would say. Tend to think it happens more with bladder issues because of its closer proximity to the bladder. But I guess if it was a large degree of a tilt, that it possibly could affect the rectum, but not that I know of.
Mm-hmm. Great. And then other than constipation, I mean, I think we've covered a lot of other things, but do you want to give some other sort of conditions that can be resolved through pelvic floor therapy? Like, is bacterial imbalances perhaps addressed through pelvic floor therapy?
Not on its own. So I would say, I do think that when there's tension in the muscles and there's not enough space, whether it's in the digestive tract or in the rectum, and this goes for vaginal conditions too, that bacteria can be more likely to form in the case where things are more restricted. So I do think it can be a helpful adjunct to whatever first line treatment's being done for the bacteria, but I wouldn't say it would on its own usually treat, presence of bacteria, like if you're talking about SIBO or something like that. But I do think that possibly people are more likely to get SIBO or have bacterial, growth wherever it may be if there's more tension going on in the connective tissue.
That makes sense. And speaking of that tension, if someone has trouble with that and is practicing relaxing of pelvic floor for constipation, but also wants to practice Kegels, is there a right balance? Do Kegels put too much tension? How do you kind of, address those two at once?
That is a very good question. I usually don't advise people who tend to have more tense pelvic floors to do Kegels unless they have some reason that they need to be doing Kegels, like stress incontinent, like something. A lot of the time, I mean, this could be a whole nother talk, but a lot of the time incontinence and other issues where you think Kegels may be the answer, there's pelvic floor tension that's causing those symptoms as well. So Kegels I recommend them very infrequently. and they can cause increased bad tension on already tense muscles. A lot of the time when you release the pelvic floor and it's able to relax all the way, we find that people's pelvic floors were much stronger than we thought because they now have like much more range of motion available to do a Kegel. So I usually don't have people doing Kegels if they tend to be in this tense pelvic floor category. Um, there could always be an exception, but I
Mhm.
don't usually recommend it.
Okay, for real, last question. um, do you work with IBD patients?
IBD, irritable bowel.
Inflammatory bowel disease.
Sorry.
No, that's all right. Yeah, Crohn's and colitis patients, or yeah.
Um, yes, you can. I mean, I would say that these types of people definitely could also have issues with muscle restrictions that are possibly increasing their pain. I mean, I would say that's not usually what brings people in, but they'll have that as um, a diagnosis like in their medical history as well. But if there's pain from inflammatory bowel disease, they very likely have issues with, guarding in the abdominal area, guarding at their pelvic floor, and they could probably benefit as well.
Mhm. Well, you just powered through 30 questions, which is a ton. Thank you so much for your extra time. Again, clearly, this is a very important topic, a lot of questions about it. We're so grateful for your expertise. We'll follow up with everyone with the recording, with the CPE certificate, the directory, and a link to the questionnaire. So, lots of additional resources to provide here. There has been a lot of express of thanks and gratitude for your time, Dr. Phillips, mine included, Epicureds included. Have a wonderful rest of your evening.
Yes,
Thank you
thank
again,
you.
everyone, for being here, and we hope to see you next month for our next clinical webinar.
Thank
Good night.
you.
Thank you.